Measuring outcomes is a part of addressing the crisis. Depending on how we define what the crisis is, we have lots more people who need therapy than we have therapists at the present moment. By using measurement tools, we can identify who we're helping and help them move on or step down from intensive services, and more importantly, who we're not helping, so that we can provide those folks with more care and more treatment. Using measures also has been shown to reduce dropout. Now, when we say dropout from services, we don't mean the clients disappear or stop suffering, but rather they simply stop coming. That also has an implication for how efficient we are as a mental health agency, because if we spend time in sessions creating a file, listening to clients, doing the diagnostic work and assessment work, and then they don't return, we've accomplished very little, and we've spent time that might be more productively spent with somebody we're helping. So I think that asking for feedback is a simple way to begin the process of addressing part of that particular crisis. Of course, we also need more providers. We also need to continue to raise awareness about the effectiveness of service, because stigma, but also a widespread belief that psychotherapy may not help me, continues to be a problem with potential consumers of psychological care. Doing feedback-informed treatment is not a method of treatment. It's not the same as CBT or IPT or whatever tea the field is drinking at the present moment. It's simply a way to evaluate the care. Is it evidence-based? We have scores of studies done over the last 20 years that shows that when therapists begin to measure their performance and then, importantly, discuss the feedback they're getting about client progress and the quality of the relationship with their clients, that can have an impact on both engagement in care and the outcome of care. Traditional definitions of evidence-based practice have been using a particular method to treat a particular problem. There's nothing wrong with that, but feedback-informed care, I frequently say in trainings, is agnostic as regard to methods. Better way of saying that is it's trans-diagnostic and trans-method. We're not having to use a particular method of therapy. You can evaluate your care and use the feedback provided regardless of the particular approach that you happen to use. The traditional approach to psychotherapy is wildly effective. Psychotherapy, regardless of the type that's being used, has an effect size that is equivalent to coronary artery bypass surgery, 4 times the effect size of fluoride in the prevention of dental caries. The problem is that we have a high dropout rate. About a quarter of our clients, a quarter of clients continue in therapy without a measurable benefit. And then data indicates that we therapists are not particularly sensitive to clients who are not making progress, or more importantly, are getting worse. And this is where the use of standardized scales and discussion of feedback with clients can be helpful. I think it could, in much the same way that following a standardized treatment protocol or doing therapy by the book, by the manual, can eliminate the human component, that human interaction. And believe me, that's the most important part of psychotherapy, that connection between the therapist and the client. So it does take some time to become used to integrating measures and feedback into your clinical work. I usually tell therapists, don't forget what you know about relating to people when you begin to use these particular scales. You have to communicate with understanding, empathy, and concern. And used in that way, I think the data show that it has a fairly profound effect, brand new study out of Holland. The lead researcher was Bovendout. In that particular study, utilization of FIT improved outcomes over and above traditional practice by 25%. So let me ask you, what method of therapy that we talk about as evidence-based has those types of results? We just don't see that. And I don't mean to downplay the challenges in implementing this, because that's another thing that Bram Bovendout mentions in his research study, that it's not simply about incorporating these two tools. Using a stopwatch is not going to improve the quality or the speed of your running. Using two measures not going to improve the quality of the therapeutic work you do. You've got to take the feedback, address the deficits and problems, and that's what improves both engagement and outcome. I doubt any therapist is going to abandon what they do because, as I said, in most instances, in fact, if we just talk about the effectiveness of the average therapist, for the last 20 years, our group has been monitoring the outcomes of real-world practicing therapists. Interestingly, those therapists in practice all around the world working with very complex cases achieve outcomes that are equivalent to the outcomes seen in tightly controlled randomized trials. That's pretty amazing results. So there's no reason why you have to modify everything that you do, except if it's not working. And then I think therapists are open to the idea and would see themselves most often as trying to flexibly accommodate and change in response to a lack of progress. That's where using measures or feedback from clients can give therapists a leg up on the process. I find out I'm not helping. I find out that the client doesn't feel connected with me. I can adjust accordingly. I think Joint Commission in particular is also talking now about measuring outcomes, and that I think is a really good thing. So adding that to whatever particular practice that you happen to use. Why the agencies have decided that using particular methods for specific disorders is evidence-based, I'm not exactly sure. You'd have to ask them. I will say that that's not ever been the definition of evidence-based practice. Somehow or other in the last 20 years, evidence-based practice has become conflated with do this method for that problem. That's not what evidence-based practice is. It's not the definition that APA uses. It's not the definition that the World Health Organization uses. I don't get it. If you want to sell treatment models, then maybe that's a great definition. But evidence-based practice has a very specific definition. The best available evidence in combination with clinical experience and the client's preferences. Now that's something I can get behind, and that's exactly what FIT is designed to do. We have evidence. It suggests that getting feedback improves outcomes. It says that you have to use your clinical experience connecting with clients within your local agency and culture, and it has to fit the client's background, preferences, culture, and worldview. That's all, at least for me, in my opinion, what FIT is designed to do. Help you connect with the client, match their preferences for treatment. It's now hundreds of years past Semmelweis's discovery that washing our hands made a difference in terms of transmitting illnesses. And he didn't even know why at the time it made a difference. And for that effort, by the way, he was driven out of the country and fired from his job. Hundreds of years later, we're still struggling with hand washing. It is one of the chief causes of infections in intensive care units in the country, failure to wash hands. So I think we have to see adoption of new ideas and evidence-based practices as something that's going to take time. What we have in our favor today, and we didn't have even 15, 20 years ago, was something called implementation science. So scientists are now studying what it takes to help agencies and individuals adopt new ideas and practices. There's a step-by-step process that begins with exploration. First, we have to give people the time to wrap their heads around things, understand what the science is saying. Second, we have to install the framework and the structure necessary to support whatever evidence-based practice we're going to do. The third step is to initially implement and use it as a learning project so that we are watching what happens on the ground and making adjustments to ensure that implementation goes forward. And then the last stage is full implementation. And at full implementation, we're really concerned about sustainability. How do we keep this going? And in particular, we're looking for a change at the cultural level within the organization. Let me just say, FIT is not about administering measures. FIT is about asking ourselves continuously, what are we going to do when this doesn't work?